This conference will now be recorded.
Okay, video after that. मैं कर पाने का चलो. Good afternoon, one and all.
Good afternoon, sir.
Good afternoon. So today we are going to the last topic of the GIT, and by the end of the class, you should answer me that what is the next system we need to start. So be prepared for that to answer the what is the next system that we can start, because you people will be knowing more better than me that what are the systems that are being dealt by the other sirs. Okay, if there is any system that is not being taught to you or not have been completed for you, then we will go with that system. Pawan,
Yes, sir.
Pawan, as a CR, you should be responsible, and you should be having a note of the all the classes that are being completed, and what are the topics that are left untaught for you. Okay, so
Yes.
today we are going to the last topic of the GAT, that is the malignant liver tumors. In the previous class, we have been taught about the benign liver tumors. That was what are the benign tumors? What are benign liver tumors?
Hydrated cyst.
Yeah, cysts. We have taught about the cysts. We have taught about the this one hemangiomas and all those things. Hydrated. And we have also discussed about the liver abscesses, their treatment, their management, and all those things. Now going to the malignant liver tumors. Of the all the malignant liver tumors, which is more important is the hepatocellular carcinoma, and which this is also a 4 marks question for you. And this hepatocellular carcinoma is the most common primary liver tumor, and it is the 6th most common cause of cancer worldwide. So this is coming to it occurs the predisposing. What are the predisposing factors for the hepatocellular carcinoma? The most common the predisposing factor is the cirrhosis of the liver, and it is seen in 75 to 90% of the individuals with cirrhosis of the liver. And coming to other risk factors, that are hepatitis B and hepatitis C infections, and the risk is more in hepatitis C when compared to hepatitis B. So you can see that the risk is between 1% in hepatitis B when compared to 5% in hepatitis C, and the duration of hepatitis B with a less duration of hepatitis C only, with a lower duration, that is 4 years 5 years of hepatitis C infected individuals can progress to hepatocellular carcinoma, whereas the person with hepatitis B infection progresses to hepatocellular carcinoma lately. That is, it takes more than 7 to 10 years. But again, when there is a history of alcohol intake and all those things, which is superadded, there will be superadded factors. So it causes cirrhosis early. Then, what are the other, apart from cirrhosis of any cause, and hepatitis B and hepatitis C infection. The other risk factors include hemochromatosis, non-alcoholic steatohepatitis, alpha-1 antitrypsin deficiency, hepatitis E-AG. That is, when will be the hepatitis E-AG will be positive? Come on, answer. When will be it will be positive? When hepatitis B, hepatitis E-AG will be positive. Usually, it is positive in when there is active hepatitis B infection. The hepatitis E-AG will be positive. So, after completion of the risk factors, then how will be the tumor appear macroscopically? So, it may be a single mass lesion initially there will be cirrhosis. There is absence of cirrhosis, or it may be single multiple nodules may present with in the presence of cirrhosis. So what is the blood supply of this tumor? It is from the hepatic artery only. It derives the blood supply through hepatic artery, and it spreads through invasion into the portal vein and its radical branches. So then lymph node metastasis is also common in these tumors, and some of the well differentiated tumors, they resemble of that of the normal hepatocytes, and these are usually difficult to distinguish between whether they are normal liver or a tumor cells. So only experts can differentiate it in the early stages. Next, coming to what are the clinical features? Usually there are two ways of presentation of this cirrhosis of this hepatocellular carcinoma. One is they present with cirrhosis per se, and other features of the liver cell dysfunction such as jaundice, varicose hemorrhages, and ascites and all those things, presence of ascites and all those things. And other one is they present asymptomatic, that is with vague symptoms, not that of the liver. That is, they present with vague symptoms such as weight loss, anorexia, and abdominal pain. So in these conditions, they're usually present in the two stages, two ways. One is with cirrhosis, another is with vague symptoms without cirrhosis. And while examination, it reveals there is hepatomegaly, and when the surface of the liver is palpated, it is irregular surface of the liver. When on palpation, the surface of liver is irregular, the suspicion should raise in your mind is it is malignancy, whether primary or secondary, because we will be discussing about the secondary liver malignancies are also in this class. So when there is a vascular invasion of this tumor, it forms the abdominal bruit may be present, and hepatic rupture will lead to intra-abdominal bleeding. So when the natural disease, sorry, if the patients are asymptomatic and presented lately, so if they in these patients, the second way of the presentation with the vague symptoms, these patients will have they present with already advanced disease. So in these patients, the curative therapy is unlikely. That is, we can't go for hepatic resection or all those things. So for these patients, extensive therapy like chemotherapy, radiofrequency ablation, and all those things should be done. So what is the best form to detect the people with hepatocellular carcinoma in early stages? Through screening of the patients who are at risk of hepatocellular carcinoma. As you all know that the risk factors for hepatocellular carcinoma. So you can also tell the patients who are at risk of hepatocellular carcinoma. Who are the patients at risk of hepatocellular carcinoma? Come on, tell me. In whom in which patients you will subject them to screening for hepatocellular carcinoma? Which patients will you subject? Come on. So you said that the risk factors for hepatocellular carcinoma is, what are the risk factors for hepatocellular carcinoma? Previously only we have told, that is cirrhotics, hepatitis B infection, hepatitis C infection, patients of hemochromatosis, and non-alcoholic steatohepatitis, and patients of non-alcoholic steatohepatitis, and these all the patients are risk of developing hepatocellular carcinoma. So these patients are subjected to screening at a period of 6-month interval. So in these patients you can detect the hepatocellular carcinoma earlier. So what are the investigations you do? Apart from the normal investigations such as ultrasound abdomen, common complete blood picture, and the liver function test, the main thing that has to be done is the serum marker that has to be done is alpha fetoprotein, and it is usually in 60% of the cases the alpha fetoprotein is elevated. So when there is a serial elevation of alpha fetoprotein, then it is suspected that there is hepatocellular carcinoma, and usually the alpha fetoprotein is used in connection with ultrasound in screening, because this alpha fetoprotein is also elevated in cases of acute viral hepatitis and all these conditions. So in these conditions, if there is a serial elevation of alpha fetoprotein, you should do a thorough investigation to check for hepatocellular carcinoma. That is ultrasound abdomen, CT abdomen, and all those things. So this is the, and imaging studies you see ultrasound abdomen and contrast enhanced CT abdomen to see whether the small lesions can be detected. But angiography is the investigation of choice, and MRI usually is done to differentiate between hypertrophic hepatocytes from the hepatocellular carcinoma cells. So this is the CT imaging that is showing the mass in the liver, isolated mass of a large mass in the liver. The arrow which I pointed is a mass. So then coming to the, then we have to confirm the diagnosis by doing a liver biopsy, and it is that this liver biopsy is usually avoided in patients who are cirrhotic and who are eligible or who will be benefited by the surgical resection, because while doing a biopsy there is every chance of seeding of the tumor cells along the needle tract. So some of the tumor cells may slip onto the needle tract, leading to a secondary recurrence of the tumor. So it is better avoided in patients who are fit for transplantation or surgical resection. And we have previously discussed the role of screening. What is the role of screening? Because it is usually done in the high risk individuals and done at the interval of 6 months interval. So these patients are the higher risk individuals are usually the patients of hepatitis B, hepatitis C infection, alcoholics leading to cirrhotic cirrhosis, and non-alcoholic steatohepatitis and all those conditions. These patients are usually subjected to screening with the interval of 6 months. Then coming to the management, how do you investigate how do you manage the case? So if the hepatocellular carcinoma is detected in an early stage with a single lesion, and the portal pressure is usually normal, then you go for a resection of the tumor mass. So if there are multiple more than three nodules less than 3 centimeters, or in conditions with portal pressure is increased. So if there are any associated diseases, in those conditions you go for a radiofrequency ablation or percutaneous ethanol injection. Or if there are no associated diseases, so you go for a liver transplantation. So this is for early stage or very early stage. and it depends on the, and again it depends on the number of nodules that are present. If single without any raise of portal hypertension, you go for resection, or any more than 3 nodules with increased portal hypertension and associated diseases, you go for radiofrequency ablation. Have no associated diseases, you go for liver transplantation. Usually the curative rate is 30 to 40% in the early stage group, and median survival is greater than 5 year survival is 40 to 70%. And coming to the, when there is an intermediate stage, that is very multinodular presentation, multinodular present, and you go for transarterial chemoembolization. So in this for embolization, you will go for embolization. It is this embolization or radiofrequency ablation, both are radioscopic directed. You ultrasound or CT guided, you will do them, and the target is on 20% only. The curative treatment is of 20% only, and survival is up to 20 months. And if there is a advanced disease with the nodal and portal vein invasion, so we will go with a chemotherapy with a drug called sorafenib. It is a TNF alpha inhibitor, and in this the target, the curative rate is 40% with a survival increase in survival in is from 6 months to 11 months. So it is this sorafenib is usually given in patients with cirrhosis and advanced stage of hepatocellular carcinoma, and is if there is those patients who are present in the terminal stage, in this case you give only best supportive care, that is palliative surgery, that is relief of the patient with from pain and all those things. So coming to hepatic resection. So hepatic resection is usually done in non-cirrhotic patients, and his 5-year survival is about 50%, and there is every chance of recurrence, 50% there is recurrence at 5 years of age. And coming to liver transplantation, and liver transplant, the side effect of this liver transplantation is, am I audible? Am I audible?
Yes, yes. Yes, sir.
Yes or no? If not, tell me. And for liver transplantation, yeah, for liver transplantation, it is a good alternative to hepatocellular carcinoma, but there is the drawback of this stage, the immunosuppression while after using the immunosuppression that we give after liver transplantation itself creates a risk for reactivation of the disease, and there is a good 5-year survival rate of 75%. 5-year survival rate of 75% following liver transplantation. Next coming to the this liver transplantation, when there is underlying liver disease such as in hepatitis C, it may recur in the transplanted liver and result in recurrent cirrhosis and giving rise to de novo hepatocellular carcinoma. So that is what we have discussed. The immunosuppression itself activates the own risks. Coming to percutaneous therapy, and percutaneous therapy is usually done with an ultrasound guided, and in these conditions, the percutaneous, there is ethanol is being injected as a sclerosing agent, and it gives 80% of the 80% of success rate, but the recurrence rates are similar to that of hepatic surgical resection. There is 50% chance of recurrence, and the radio frequency ablation is usually done with a single electrode being inserted in the tumor mass, and a frequency and radiotherapy is usually given, and it is also the for insertion of this electrode also it is ultrasound guided. So coming to next, transarterial chemoembolization. For this you will give galform and doxorubicin and it is more effective, and survival rates of 60% in cirrhotic patients with unresected hepatocellular carcinoma and with good liver function. And this condition is contraindicated in decompensated cirrhosis and multifocal hepatocellular carcinomas. Next, coming to chemotherapy, we have discussed chemotherapy with sorafenib. It improves the survival from 7.9 to 10.11 months. That is, it improves the survival by it prolongs the survival by 3 months, roughly of 3 months in cirrhotic patients. Next, it is already discussed is a TNF alpha inhibitor and all those things. Next, coming to the other condition, that is fibrolamellar hepatocellular carcinoma. It differs from that of hepatocellular carcinoma in that it occurs in young adults. When compared to hepatocellular carcinoma, it is seen usually at the age of 50 or 60 years. But this fibrolamellar hepatocellular carcinoma occurs at early age of 30 to 40 years, and females and males are equally prone to the disease, and it occurs in the absence of hepatitis B infection and cirrhosis. And usually, while detection, the tumors are often large at the presentation, and alpha fetoprotein is usually normal in this condition. So when histology is being done, this tumor reveals the malignant hepatocytes surrounded by a dense fibrous stroma. And what is the treatment of such this fibrolamellar hepatocellular carcinoma is? It is surgical resection. And when compared to hepatocellular carcinoma, this form it has a good prognosis with 5-year survival rate of 60%. And now other primary malignant tumors include hemangioendothelial sarcomas and cholangiocarcinoma. This hemangioendothelial carcinoma is very rare, whereas cholangiocarcinoma presents with bile duct obstruction per se or under bile duct obstruction due to hepatic mass compressing on the bile duct. So these cholangiocarcinoma patients usually present with jaundice, that cures by itself. Again, the jaundice appears. Then coming to secondary malignant tumors. These are the most common malignant. These secondary malignant tumors are mostly metastatic tumors. Usually, they metastasize from the carcinoma of the lung, breast, abdomen, or pelvis. These secondaries may be single or multiple, and most of the times they are multiple. And there in secondary malignant tumors, you can also see the peritoneal dissemination. When there is peritoneal dissemination, you can see it results in the ascites of the ascites. So what will be the clinical features? Usually the primary tumors are asymptomatic, and these primary tumors are detected when investigated for the signs of liver cell failure. Then that is in a patient who presents to the OPD also with the features of ascites and all those ascites and signs of other liver cell failure, such as jaundice and all those things. In these cases, when you investigate, you will see a metastatic liver tumor, and when you subject the person to thorough investigation, you will find the primary tumors. And it shows that alpha lipoprotein is elevated with liver function test being normal. And when the patients with the peritoneal deposition you will see ascites, and when you subject them patient to ascitic fluid analysis, it shows that the ascite and there is increased protein content of the fluid with sometimes the tapping is also red. The fluid is also blood stained. Again, it also shows that when subjected this ascitic fluid analysis subjected to cytology, you will see the malignant cells are usually present. So this is the CT image that is showing multiple secondaries, small secondaries that are present within the liver. These are the small secondaries that are present within the liver. And this is a CT image that is showing the hemangioma. That is this white one is the hemangioma. Then coming to the management of the secondaries, usually if there are single, you do a hepatic resection, and some the hepatic resection is the treatment of choice for slow growing tumors, followed by removal of the primary, and followed by chemotherapy to reduce the recurrence. And the patients with neuroendocrine tumors such as gastromas, insulinomas, and glucomas, these and with lymphomas, they benefit from the surgery. And next one is the arterial embolization. It is usually arterial embolization is usually done only for the liver tumors and the renal tumors. So this arterial embolization will cause the decrease in the mass tumor size, which further leads to relieves the pressure symptoms and all those things. So this is about liver tumors. Is there any doubts?
No, sir.
Any doubts? No. What is the then? Tell me what next topic can we start in the next class?
Endocrine, sir.
Endocrine. Endocrine is not being dealt to you.
Actually, Raghava sir has started, sir, but he had left, sir.
Up to which topics have been completed by Raghava sir?
Introduction, sir, about HPA axis and all.
About
Hypothalamo pituitary axis and the hormones.
hypothalamic pituitary axis only he had taught. Only
Yes, sir.
only started the endocrinology.
Yes, sir.
It started. Only 2 classes is over.
Yes, sir.
Okay. So I will see whether to continue with the mostly I will continue with endocrinology or with any other diseases such as diabetes, mellitus, and all those things are not dealt to you now.
No, sir.
So we will go with we may go with diabetes or endocrinology. Okay.
Okay, sir.
Yeah. Thank you all then.
Thank you, sir.